180, and we're at the speed down to 2,500.
Point wherever you reduce speed to 180.
BlackBox.
Hey, welcome back to the podcast. I need to go get some some So I got a great guest today. It's going to help me with my brain therapy and help me with my speech and articulation and my cognitive ability. There we go. So I'm here with David Day. David was referred by Dr. Marsh, who's my chiropractor, and we were talking about brain therapy and what was happening in that world. And he was like, "Man, you gotta interview David." So Ian got on the podcast, or on that right after that podcast, right. I think called you and made the introduction and said, "We got to get you in here quick." So, thanks for coming in on short notice and having an opportunity to share with us, the great things that you guys are doing in the world of brain therapy.
Right. Well, thanks for having me. I appreciate it. It's great to be able to give back to the community.
Yeah. Well, we were just off camera, kind of on camera. I'm sure they'll pick up some of that in our interview. But we're fellow Marines and sailors, and I always like to tell my sailor friends, I'm a Marine, and Marines are a department of the Navy, the men's department. You knew that was coming, right?
That's right. Remember, I've got your shot record.
That's right. So there was a love-hate relationship between Marines and sailors, but Marines passionately love the doc, the corpsman. And you started out a corpsman.
That's right.
In the Navy, which is you're a Marine, right, just with a med pack on your back, right?
Exactly. Yeah, I sure did. I enlisted in June 26, 1990, out of Spokane, Washington, and joined the Navy to become a hospital corpsman, and went through boot camp, Corps School, there all in San Diego. And then my first duty station was actually 29 Palms with the Marine Corps.
The Stumps.
Out there, yes, indeed, out in the Mojave Desert for 5 glorious years of
my Jarhead brothers,
right.
Gotta love it.
Right.
Well, let's do this real quick before we get into this amazing magnetic resonance therapy that you're doing and how you're helping our finest and those that have served, and even civilians. So I don't want to forget. We'll talk about them as well. But we always like to do a little toast to our nation's military. So I'd like to toast you and say, hey, thanks for your service. You served well. You did 20 plus years, retired, enlisted, and then got a commission. So good for you.
Right.
I didn't need enough crayons to get my commission, so I'm jealous. Good for you.
Well,
but again, cheers to our nation's
Cheers
military.
to our veterans.
Yep.
And those still serving.
Those still serving. Talk to my son. You got to meet my son this morning. He called in.
Isaiah, hi. Shout out.
Yeah, shout out to Isaiah. He's up at the 101st.
Yes. Yep.
Those Screaming Eagles. So cheers to those guys.
Salute.
Little Johnny Walker. We're trying to get Johnny Walker to send us a bottle of Blue Label. We're getting low, Johnny Walker.
Oh.
We started that, guys, about 4 months ago? Less than that. So we're over halfway. So I'm estimating we'll do about 3 of those a year, those magnums there.
Wow.
Just in toast.
Wow.
Unless these guys are dipping into it and they're not telling me during
Where's
the day.
the camera?
Right. But, it's important in terms of what we're going to talk about today, because what you're doing and what we're trying to do for our nation's military and these warriors who are coming back with sometimes debilitating illnesses and disease, and the mind, that important organ that's sits in that cranium,
that box
thing, like mine. My big grape ape is what they called me in boot camp. It's important to treat that well.
Absolutely.
So without it,
there's only one.
Yeah. So take me back to this young corpsman, and if you can, in a matter of a few minutes, take me from corpsman to physician's assistant to magnetic resonance therapy expert, and helping patients with all kinds of different, from PTSD, anxiety, traumatic brain injuries, ADHD.
Right.
So start me back at this this young man who enlisted in the Navy and how you got to where you are now.
Sure. So, just after boot camp, served my time with the Marine Corps, both in 29 Palms and Okinawa, Japan. Applied for the Medical Service Corps In-Service Procurement Program, also known as IPAP, which is one of the largest PA programs in the country. It's a tri-service program. So our first phase was in San Antonio, Texas for a year, and then to San Diego for all the Navy folks. Other services branched out to their respective hospitals and follow-on programs for basically clinicals. I finished that up and reported to the Pentagon in Washington, D.C. as an ensign,
Wow.
as a Mustang ensign, with a small rack of ribbons. But for an 01 Sir Butter Bar, it was a little bit unique. But being in D.C. after 9/11 was pretty remarkable to see.
Yeah, most of the senior guys are looking at you going, you got busted. What did you do?
Right.
And they see
Right.
yeah.
Yes, exactly. What happened?
And the young guys are like, wow.
Right. So, but to be at the station at the Pentagon after 9/11 during the D.C. sniper shooting was really an incredible, eye-opening experience.
Yeah.
To move my family to the East Coast, to live in our nation's capital and see everything that was going on was pretty remarkable, especially after such a tragedy for our nation. But it invoked a lot of patriotism, a lot of pride, a lot of united, citizens.
Yeah,
throughout
more of
the
what we
country.
need today, right?
Absolutely.
We need to get back to that, for
Absolutely.
sure.
Right. We're all Americans. That's what
right.
we need to remember. We can have our differences, but respect one another.
Yeah, that's the great thing about wearing our nation's uniforms, whether it be as a sailor or as a Marine. I remember a drill instructor, and this is, in the 1990s, and, good, bad, or indifferent, that period of time, the racial divide, I don't think was anywhere like what it is today. But one of the things I appreciated about the Marine Corps is that one of my senior drill instructors, I'll never forget him, Sergeant Glimp. So shout out to you, Sergeant Glimp, if you're out there somewhere.
Hoorah.
Hoorah. He said, in my Marine Corps, there's no color, only light green Marines and dark green Marines. And he just wouldn't put up with, and this is a black dude.
Right.
He just wouldn't put up with any BS.
Right.
And we all had this unspoken bond that it didn't matter whether you were Taiwanese, Japanese, Chinese. If you put on that uniform, you were a Marine.
Right.
And you were there to serve a common cause. And especially if you're an infantry Marine and,
Right.
as a doc, serving with infantry Marines, kind of a different breed there. They're,
Right.
Young, crazy 19-year-olds, smart enough to listen but dumb enough to go do it. And the sergeant says, charge the hill,
Right.
they're doing it.
Right.
A lot like the community I guess you served in the spec war world. But point being, I don't want to get too far off today on this whole political tangent, but it shouldn't be a tangent. It should just be, hey, you know what? We have a common bond. We're U.S. United States of America, U.S. citizens who are there in spite of our differences can find a way to unite. So
Absolutely.
it's an important time to keep bringing it back to that, especially in this 2020 election year
Absolutely.
where there's been a lot of rhetoric and divide. And one of the beautiful things I think about what you're doing is that you're offering a way for people to have some healing, some mind healing. So what got you into magnetic therapy, or do you call it MERT, or
Right, we call it MERT or MERT.
MERT,
also,
okay.
The headquarters company is looking at kind of rebranding it, but that's probably to be follow on in 2021. But
Okay.
Right now it's called MERT, so magnetic e-resonance therapy. The E stands for EKG and EEG, so electroencephalogram and an echocardiogram.
Yeah, I'm gonna have to give you some Tyson on that one. No, I won't. It's having an EEG problem. My pad over here is not working. We'll just give myself. There we go. So, okay, all right, settle down. So EEG, EKG, you're doing these wave
Right.
measurements.
Right.
So explain that to me and to our audience.
Right. So one of the first steps when we have my initial consultation with a patient or a parent of a patient is we want to assess the risks and benefits of the treatment and if there are any contraindications for the treatment. If it's too risky, then we'll have to say, hey, basically this is the risk. It's too much for us. And there are some inherent risks, and those primarily being a risk for seizure disorders, number one. But as I like to tell the folks, with a video game console you can go buy over the counter down the street at their local store, there's a risk of 1 in 4,000 people that have that seizure. With this treatment modality, you're talking about 1 in 100,000 people as far as having a risk.
All right, so take me back to that for a minute. So, my kids grew up with Xbox and Sony PlayStation and those games, and every once in a while I would play.
Right.
They could play those first-person games and be fine.
Right.
But for me, I would watch this TV screen and I would get so in tune that I would start getting dizzy and feel faint and sick from the movement on the screen. What was I about to have a seizure, or what was?
I don't think you necessarily were going to have a seizure at that moment in time, but you may have just, so it depends. There could be eye fatigue, there could be strain, just maybe that whether you got a good night's sleep and it's just too much excitation, other things that would come into play. But for those that have had histories of seizures playing these type of games, maybe they did know about it and thought it was minimal, or someone who maybe had a childhood febrile type of seizure but never really got worked up, and then to induce this type of seizure with a video game system, it's a possibility.
Have you personally seen that happen to a patient yet, where you've had anybody?
No, we have not. I have not had anyone.
So the risk is 1 in 100,000 is
right.
Yeah,
that's low when you're comparing to a video game off the shelf that's with 1 in 4,000 people,
right,
which plainly shows on the label that risk. It's pretty remarkable. And then when you're talking about risks of medications as well, this being a non-pharmaceutical treatment modality, it's definitely a benefit of being able to help someone.
And your treatments are, back in 1985, you were telling me off camera, were approved FDA. So kind of
correct.
Not that FDA likes to call itself the gold standard, or but
right.
If you've got the Food and Drug Administration saying, hey, this is an acceptable form of treatment that's been tested and vetted.
Right.
So take me through this vetting process of MERT and what it does.
So with the FDA's approval in 1985 for the TMS, which is repetitive transcranial magnetic stimulation, that hardware, that device.
These are massive words. Blowing my mind here.
That technology, basically they're talking about a MRI coil, a magnetic resonance imaging coil, same thing we'd use for getting imaging of a body part. They basically have condensed that down to a hand-sized coil, about 8 to 9 inches in length, weighs about roughly 10 pounds or so.
Wow.
But that magnetic energy has a field that can invoke a precision potential for each individual's brain. So the FDA approved it in 1985, but then in 2008 it received approval for the treatment of depression, typically resistant to 1 or 2 classes of antidepressant medications. And so when you're talking about insurance carriers and billing, they'll typically want you to go through 1 or 2 medications, do therapy, before they'll consider allowing this as a treatment option, which seems kind of reverse when you think of the safety profiles and the efficacy of it. But that's kind of where we're at with the rules right now as it stands. But in 2013, it was approved for migraine headaches, and then in 2018, obsessive-compulsive disorder. So there are additional studies that are being done throughout the United States and world with various universities for the efficacy of this treatment in other disorders such as PTSD, traumatic brain injury, stroke, autism. So there's the ongoing. So I think once they have more of those studies, it'll validate what we're doing with MERT is a personalized approach to the transcranial magnetic stimulation.
So post-traumatic stress, that's been a big word, especially since 9/11 and being at war for almost 20 years now. And we've learned a lot since back in the day when I was growing up. We had an uncle that was in the Korean War and an uncle that was in World War II, and we called it shell shock.
Right.
So that understanding of post-stress, post-trauma stress, that doesn't necessarily have to be war. It could be financial. It could be emotional, of any sorts, right?
Correct.
Now, so you're treating people who aren't just warriors coming off the battlefield dealing with post-trauma.
Right.
It could be a person who maybe saw something happen horrible in their neighborhood or reliving a childhood experience.
Right. I think the Veterans Administration did a study, and I think one of their findings with as far as the PTSD goes, I think one of the largest groups they had wasn't necessarily from war-related, it was sexual assault and trauma.
Wow.
From that regards. So when you're talking about having a modality that can, and giving the diagnosis of PTSD or depression, anxiety, ADHD, autism, those are all diagnoses that people are given by their specialists or providers. When we're evaluating a patient, yes, we want to know what their medical history is, their psychological history, their neurological history. So we do get a background of what their assessment has been and their diagnoses, current medications. But ultimately, we're obtaining that EEG, which is a quantitative electroencephalogram. It takes about 15 minutes for us to get everything set up, but 10 minutes, eyes closed in a resting state. We're looking at that brain and basically understanding where the electrical activity is occurring for each of the different brain frequencies for each individual. So after we complete the EEG, we're able to tailor that treatment for each individual specifically to their inherent, their optimal brain frequency.
So question for you, if you haven't done a baseline of a patient who comes in with some type of treatment, or you have some type of treatment plan, how do you set a baseline for someone who's coming to you with a problem? And if you're getting an EEG that shows you the current brain function, what do you compare that to? And in your treatment plan, do you take that first EEG analysis and then compare it to a later analysis to see how they're doing?
Right. That's correct. So when we conduct the initial baseline EEG, it's your baseline, but then we're also comparing it to a very large normative database of over 25,000 individuals that are called normal EEGs, and we're comparing those EEGs with your EEG. So with that, we now know that, okay, these are the typical brain activities that we're seeing from delta, theta waves, alpha waves, and beta wave activity. We know where the brain is oscillating at these specific frequencies. So when we're looking at your brainwave activity, we're able to fine-tune your treatment. And you may be, the range for an individual in an alpha state can be anywhere from 8 to 13 hertz. So we're able to fine-tune the treatment basically to your inherent optimal frequency. So I like to tell folks, look, I can't make you a LeBron James, okay? But if you are LeBron James, we can make you a better LeBron James, okay? If you're an assaulter or a Marine, we can help, or CEO, we can help you by fine-tuning the brain activity, so improving that synchronization of the brain activity. So those hundreds of billions of neurons are now communicating more efficiently, and there's less disruption in that neural network. So I know for those that live here in Tidewater, you can relate driving on the 64 and having to go up to Williamsburg. If you could take the HOV all the way, that'd be pretty sweet.
Right.
But if
more
you're
efficient,
stuck, right, you're more efficient. But if you're having to weave in and out of traffic on the regular side of the road, less efficiency, more fuel consumption, stop and go, a bit of a challenge and frustration that's dealt with that. So if you're looking at your brain and how those hundreds of billions of neurons are conducting that information, you can relate and go, I understand now. If there's a smoother, faster process, I'm consuming less fuel, it's more efficient.
Yeah. So can you, without obviously under HIPAA and patient disclosure, can we make up some patients that, protecting the innocent, change their name and give me some ideas of some patients that you've worked with in this type of therapy and what benefits you've seen?
So by and large, I've treated veterans from the special warfare community, veterans and their family members as well that have suffered traumatic brain injury. Some of those have also had early
onset. Give me an example so that folks can have an understanding. When TBI, we hear that when we think of NFL and football and just head-on collisions, but warriors.
Right. So one of the more recent cases we had was an individual, was a SEAL veteran, had served 9 years basically as a breacher, and had gotten out and was now actually a first responder living in the Midwest as a firefighter, paramedic, and he came to us in need of help. So we were able to bring them in.
Symptoms being what?
So primary symptoms of sleep disruption, the mood, irritability, depression, anxiety symptoms, the PTSD symptoms. So he'd already been given all of these diagnoses, had basically been on 11 different medications, and switched in and out different facilities to have evaluations. But no one was really able to offer a treatment modality that was beneficial. I did counseling sessions, CBT, cognitive biofeedback therapy. So there were other things, and some of them did help, but it was short-lived. And then with the medications, there's the interactions with the medications. Now you've got medications to help sleep, and then you have medications to help get you awake. And so when you're talking to an individual who's working as a first responder and working through shifts, it's very challenging for this individual, and having to snap when the bell goes off to get in the truck and go and handle a crisis was very challenging.
How hard is it, David, when you have a person that's on 11 different medications, you're trying to establish a baseline with his EEG. Is there any protocol to say, hey, we need you to be off these meds for a week, 2 weeks, 3 weeks before you come in, or do you take them as is?
Right, and that's a good question. So with each individual, there is a review of what medications are on, and the goal is to help them taper off their medications so that the therapy itself can have a better, longer-lasting effect, because some of the medications out there can cause some problems with the treatment itself. So in particular, benzodiazepines such as Valium, Xanax, those are some of the medications that can inhibit or slow the ability of the treatment process itself.
So are you working in coordination with those doctors who have prescribed that medication?
Right. So we'll be in touch with the individuals, or we'll inform the individuals, hey, let your provider know that you're going to receive this treatment. If they have any concerns, certainly notify us. But the goal is that we want to safely taper you off the medications. And then that's usually over could be a week to 2 weeks to 3 weeks. And we have a daily interaction with the patient to assess how they're doing. Are they having any side effects with the treatment? And then we can adjust that as necessary.
So if you can, give me like a fifth grade, because, man, I haven't had your therapy yet. And so cognitively, I'm like, all right, I got this magnetic resonance therapy, and I can break those words down and maybe assimilate in somehow how it's going to work. But can you help us understand what a magnet's doing to my brain?
Right. So with the magnetic coil itself, it generates that energy field. All right. So the sensation actually feels almost like a less than like a static electrical impulse. Okay, so that magnetic coil is
in my head, or
right through the coil, the magnetic coil, which is placed typically over the forehead.
Okay,
that is able to transfer that energy at a precise frequency to your inherent frequency, and it does that over several clicks or cycles or oscillations for that device, and with it is able to gently coax your brain to fire at that frequency. Okay, so that's why we obtain the EEG to find out what's your optimal frequency, target that, set the protocols for it. And
so REM years ago, with their song "What's the Frequency, Kenneth?" They were onto this, right? They were pioneers.
They were men ahead of their time. So,
man.
but this.
Sorry, I dumbed it down.
But we're able to transfer that energy about 2 inches into the cortical tissue of the brain. So it is able to pass through the skull, the bone itself, and then into the cortical tissue. And then we also have safety protocols in place where we limit the amount of energy that's being delivered. Standard TMS on the market delivers at 10 hertz in frequency, whereas we can go anywhere from 8 to 13, tailored to you. And then on top of it, we're also the motor threshold, the energy, the percentage of that energy is also, we're able to tailor that to each individual.
Yeah. All right. So while you were sharing this with me and you're talking about how you're able to use this magnet to get online with my particular brain frequency.
Right.
And you can hone it in.
Right.
Does that play into, and I don't want to make it conspiracy here, but you've heard probably some of the scuttlebutt or rumors out there about 5G.
Yes.
With phones. So is that a similar concept that those waves and how cell phone waves, cellular waves can affect our brain if we have too much. Can you have too much of a good thing, I guess is what I'm coming back to.
There's, depending on the individual, it's going to be a little bit unique. So with our treatment, after around the 9th or 10th treatment, we'll repeat the EEG to see what progress we've made, or has there been any progress with the brain. Most of the individuals that we are treating will see a movement, a shift in that neurosynchronization of their brain. So that's ultimately what we're our benchmark is being able to get the baseline, compare it to a normative database, do the treatments, repeat the EEG at the 10th treatment, and we can see, okay, are we moving? Are we moving the needle? And are we getting that neurosynchronization? I recall there was probably about 2 months ago we had looked at an EEG. The clinicians worldwide, we usually have a meeting once a month, and they put up a case scenario of an individual who was a special operator from another country, but had just this beautiful EEG. I mean, it was just so impressive, and there was no other activity other than this great looking alpha frequency. But what was reported that the person had basically no affect, no emotions. And so we were all kind of like, wow, that's pretty amazing. Individual had sustained a pretty significant trauma. And then come to find out he was just like a machine, just a robot, no fluctuations. And you are supposed to fluctuate through your different brain waves, that beta, that alpha, that theta, and that delta activity. So when you say too much of a good thing, that was a good case scenario of an individual who had too much of a good thing. Everything looked perfect. It looked lined up. But, you're kind of thinking the Terminator, this is all, it was just a robot. And so my understanding was with the treatment, they were able to shift just a half a hertz. And that half a hertz was enough to have a dramatic impact on the individual, their affect, their emotions, their mood with their family.
This is some freaky stuff, actually, because I've been, with what's going on with COVID.
Yes.
And there was, a mass amount of information that was coming out that, it was the Chinese, gave us this illness. But there were some people who were trying to draw the line between the illness and the release of 5G and how they could control human beings with frequencies.
Yeah.
So what I'm hearing from you in treatment, taken out of the context of patient physician or patient clinician, there are people out there who could be nefarious with this stuff then, I guess, right? Is that possible?
If just under non-medical review and peer review of that technology, sure, there's anything you could take anything and potentially make it nefarious. But if you're asking about the 5G, I don't know.
Yeah,
that's the first I've heard of it. But when we're talking about a medical treatment modality, this is pretty specific. I don't think I'm going to be able to stand on top of the Hoffler Center here with a magnet and disperse a brainwave activity. It's going to turn us all into just
submissive servants, right?
Right. Now, I don't think that's going to quite happen quite at that level. But I think each individual with the treatment, you are able to have an effect on different domains with their mood, their irritability, their sleep. So there's lots of different things that can be treated with this one modality, which is pretty impressive.
So does the doc subscribe to, does the clinician subscribe to self-treatment? Do you and your partner, do you guys use this personally for yourself to manage your own care? And do you mind sharing that with us if you do, and what that looks like? So
in the past, I had treatment, and it was for my ringing in my ears. It was military. We talked about that earlier. So I had tinnitus, ringing in the ears. Was on board the. My
ears are ringing right now. So
yes, I was on board the aircraft carrier, the USS Theodore Roosevelt, CVN 71. Shout out for those folks, that crew, and then also my time 5 years that I was spent with Naval Special Warfare. So exposed. We
can't shout out to those guys. We'll let it go at that.
So exposures to blasts, gunfire, those different things. So machinery equipment, jet noise. So I had a pretty significant amount of tinnitus, some hearing loss, but where I found for myself as a patient or a clinician interacting with my patients was that just even in an exam room with the vent blowing down, I was having a hard time hearing the patients in meetings, understanding my colleagues. So eventually led to me getting hearing aids. But I was out in California when we were looking into this technology. And they said, hey, we're working on a protocol for the tinnitus. Would you like to try it? At that point, I had already had my hearing aids for maybe a year or so. And I said, sure, go ahead. Let's go. We'll go ahead and do it. So they did the treatment. It lasted 5 minutes. And to my shock was that the tinnitus that I had was gone. Literally, I'm walking back into another room and hold my hands over my ears and trying to hear that high-pitched ringing.
Right.
And it was gone. So I was pretty convinced that, wow, this had some efficacy without any side effects. Now, the treatment, did it last? Well, one treatment session, it lasted for, I would say, about a month, and this was probably about 5 years ago that I recall doing it. So it did help in that regards. So to answer your question, yes, have I had a treatment? It was for that particular experience, and it did help. So
give me a normal case study of a patient that comes to you that has a TBI. What is the treatment range? What would that person, and I know each patient is different, but what do you typically do? What could they expect when they come into your office and start this type of alternative therapy?
Right.
Or mainstream therapy, maybe it sounds like now.
Right. It's an option.
Yeah.
It's an option. And that's what I think, we want to let folks know is that, hey, there's something else out there besides medications and some of the counseling, CBD. There's another alternative for you that may help. And it's safe. It's effective. It can be effective. And so with the initial intake for us, our potential clients, they can schedule a consultation online with us or go to the website to do more research.
By the way, your website, let's go ahead. We'll give a shout out to your company is NEUCOA.
NEUCOA.
NEUCOA, thank you. Take me through it. So NEUCOA.com.
Right.
NEUCOA.com.
That's right.
Explain that name. It was pretty cool. You were sharing that with me before we started.
So having been a clinician and a military guy, it was when I approached my accountant, my fiduciary, and my attorney about a name, and my partner, as far as a name for the company. We didn't have one. We just needed to get things up and running as quickly as we could. And so you're tossing and turning and losing some sleep over, okay, what are we going to name this thing? Military guys, military folks loved acronyms, all right, so couldn't get past that. And so that's where it kind of dawned on me in one of those early morning wake-ups and not being able to fall back to sleep was Neuro Enhancement and Cognitive Optimization Associates, so NEUCOA being the acronym. COA in the military is a course of action. The new part was a play on words, so I found it interesting. But then when folks are looking at the name, they say, what do you do? Well, look at the name. What does it say? Neuro Enhancement, Cognitive Optimization. That's pretty much it.
Yeah.
So with
that's
that,
cool.
It was just kind of a funny thing for me as far as like, hey, this is a new dimension of medication or a treatment modality that we're able to apply for our community.
Mainstream, so folks who are listening today who may not be in the military, may not have a TBI, but I was looking on your site, ADHD, ADD, spinal cord injuries. Tell me how it can help with those.
Right. So it goes back to, for the ADD, ADHD component, it goes back to we're looking at your brainwave activity. And typically what we'll see is those individuals that are suffering from ADD, ADHD, anxiety, they'll typically have the higher end of beta activity, always going, racing mind, can't turn it off. Now, you do want to have a healthy amount of that beta activity, but if you're not able to flux in between those brainwave stages, then that's when it becomes a problem. Same thing if you're on the slower spectrum of delta or theta waves, which is theta considered more of a meditated state, and delta being a deeper sleep or unconscious state. So if you're not able to flux in and out of those stages, then that's when you start to have more clinical manifestations that are more prominent in your daily life. So for those individuals with attention deficit disorder or hyperactivity disorder, we'll typically see those higher amounts of that beta activity. Yeah. So by doing the treatment, we're able to help adjust that brainwave activity, specifically the beta, and get that neurosynchronization, so they're not overconsumed by that anxiety or attention deficit type of disorder. Spinal cord injuries are a different thing.
Okay.
So we've had two individuals that suffered spinal cord compression injuries. One was a veteran, another was a civilian. And what was unique is that we weren't just doing initially it wasn't the cortical treatment. We have the ability to do a peripheral treatment. So there's a different coil.
Explain those for me.
So the cortical is for the brain.
Okay.
So the cortical is the brain treatment, which we're using to help for that neurosynchronization. The peripheral coil is a coil that we use to treat the extremities or the spinal cord itself. So we've had those individuals with spinal cord injuries that have suffered the compression fractures, and as a result, they may have paralysis, they may have loss of sensation, or in some cases, both of those. And so what we are able to do, chronic pain is one of the things that our patients may have. So the peripheral coil may help. It's proven to help these individuals that are suffering from some of the chronic pain issues. So this one individual we had, when asked about his pain that he suffered on the upper extremities, 1 out of 10 is typically what we say is 1 out of 10, what's your pain? He said a 13. A 13 out of 10. All right. Hard to believe.
Yeah.
But he was also a veteran and had a pretty significant pain tolerance. And then looking at the medications that he was on as well, neuropathic medications, chronic opioids, all these different things. It was it was a cocktail of.
So he was high all the time at some state, high or low.
Right. He was on a lot of medications that were altering his neurochemistry and his cognitive function and ability. On top of it, he was still having the pain. And then the lower extremities,
Miserable.
He had no 2-point discrimination. So what we're talking about is ability to feel any sensation in his lower extremities, in particular his feet and his leg. He said, I had actually burned myself. You think it wouldn't be that big of a deal not to have sensation. He said, I burned myself because I didn't realize that something hot had spilled on me. So we literally did the first day of treatment on him, the lower extremities, and my partner was treating him, and I was doing the testing, and we literally had he started that first one, that session, and he says, I can feel that. So we were doing a low frequency. One treatment. And it was during the treatment we were doing it, and he was able to feel a 2-point discrimination in his toes, of all the things. So a distal end, and he said, I haven't been able to feel that for 18 months. Totally remarkable. Then we moved up to the upper extremities and treated the spine, and then branched out to some of the peripheral regions of his upper extremities. And we were able to reduce his pain. He went from a 13 out of 10, okay, which is well exceeds the scale, to a 0 out of 10. He walked out of there without any pain and had sensation. Now, the next morning, came back in.
So when you
treatment.
say walkout, did he have paralysis, or was he just numbness feeling?
Right, he had numbness. So he was one of the spinal cord injuries patients that was able to ambulate. He was able to walk, but he just didn't have that sensation. Now, albeit there were some differences in gait and stuff, but
sure.
But the next morning came back in. He says, "Wow, I was able to sleep. I was coming off came off his medications as well. His pain did return. He was at about a 6 out of 10. But not a 13 out of 10, which is where he was at with medications. So we continued treatment, and we were able to get him off his medications. And we only did, I want to say it was about 3 weeks of treatment or so. But to be able to keep him off his medications to give him sensation back was phenomenal. So,
I'm a thick-headed Marine, and I'm baffled. So, numbers, math, consumer finance, I've got you, I'm there. But what is this doing to the brain? I mean, those brain waves. And you're aligning these frequencies. Mm-hmm. What's the science? If you can dumb that down for me.
So we're going to go back to the cortical part of it now. Okay, so the brain, as far as the brain treatment. So your brain consists of over 100 billions of neurons. Okay, and they're exchanging information via these electrical signals through the synapses. Okay, so devil dog, go over there, send a message. All right. So if you have a disruption in that neural network, all right, and you can see this as you're doing drill, right?
Yeah, right.
So if you got a devil dog that's off to the left or right, and they're just kind of running around, all right, but they're not in sync with the formation, okay, what we're doing is we're telling all of these guys either, hey, you pick it up or you slow it down, but fall in line.
Yeah.
Okay. So the hundreds of billions of neurons that you have, if they're not firing in sequence or marching in sequence, we're helping to get those folks back in alignment. So those boots on the ground, sometimes we're increasing, but with the electrical activity, we'll see that is there's an increase in amplitude. Okay, so the amount of electrical activity that's being generated by the brain. And we commonly see that in a lot of our veterans that have sustained traumatic brain injuries is they'll have low voltage, all right? What that means is you've taken a hit, your brain says, I'm checking out, taking a nap, all right? So they go dormant. How do we wake them up? There's nothing out there, right?
Wow.
So a person goes in, sees their doc, says, I have depression, I have problems sleeping, whatever it is. So they give you a pill. And that pill, what is it doing? It's trying to upregulate or get those neurons working again, but it's through neurochemistry, electrical charges, right?
Yeah.
Those neuroreceptors either upregulating or downregulating, blocking. So what we're doing is we're skipping all of that. We're taking that energy directed at your inherent frequency and saying, okay, this is where we want you to move. Based on your EEG, this is where we need to move you to. So we can now say, hey, boots on the ground, start running. You were at 1.6 hertz in frequency. All right, now we want you to start running about, let's get you to 6. So we do the treatments, and we're slowly moving it. We set your goal, okay, maybe it's like 10.5. But we're not going to just take that slice of energy and all of a sudden jump to 10, okay? You're not going to run your PFT and do a 16-minute PFT, right?
Right.
Maybe you're a 24-minute guy,
okay?
But as we start doing training, we start doing some gym workouts, strength conditioning, whatever it is, and we're getting you built up. That's essentially what we're doing, is we're helping the brain to go, okay, I can march faster, I can move faster. So as we start to recruit more neurons, we're telling them, hey, this is the frequency. This is the pace we want you to start moving at. Oh, okay.
So I saw on your site, and I haven't had a chance to go in and read it yet, but there was one portion where you were working with stroke and stroke patients. I don't know if you've had any stroke patients yet, but someone that has a part of their brain that has effectively died, and so those frequencies aren't hitting in that portion of the brain anymore. What can you do about that?
So the unique part is, and there's more studies that are ongoing with the efficacy and validating MERT or TMS for the treatment of stroke. But essentially, if you're looking at a person's brain and where a stroke event has taken place, a cerebrovascular incident or an aneurysm for that matter, first and foremost is there any type of metallic items in the brain, shrapnel, frag, clips, coils, anything like that. If that's the case, then it's a no-go, because obviously you can't put a magnetic coil to that. Same thing if you have a pacemaker, a defibrillator. We don't want to disrupt that. Cochlear implants for hearing, we can't, anything that has a magnet or metal to it, we can't, it's definitely not recommended for treatment. We wouldn't treat you. So
you're going to be ripping it out of their head.
Yes, we're not going to do that. So with that being said, when we're talking about a stroke patient, we're looking at how can we help reroute that. Okay, we're looking for a detour or a bypass. Your brain has the ability, it has the ability for whether it's the motor cortex or the sensory cortex as well. So the brain has the ability, has an inherent ability to help heal itself, but you have redundancies that are built in as well. So if we can help train the brain to say, okay, just because there's a roadblock doesn't mean you need to stop. Okay, we have to continue to function. So we're helping the brain to go recognize that, okay, there's alternate pathways that we can go around. With hundreds of billions of neurons, we can reroute traffic and go to this other side and get the end result. Now, even some individuals, okay, there's a story out there of an individual who was shot in the head, was a veteran, had 57 millimeters of the right motor cortex was shot.
Give me in millimeters for us in the
inches.
Yeah.
So you're talking roughly 4.5 inches of roughly of the right side of the brain was missing. The individual had gone through rehabilitation and treatment, was in a wheelchair, basically had no motor function of the left side of his body. And the individual was treated by the clinic out in California. And what was truly remarkable is they had video documentation of this, but the ability of that proven to show that we can reroute or show the brain, teach the brain how to work again. So this individual went from being in a wheelchair to, within 2 months, being able to stand up in a swimming pool and walk with aquatic therapy.
Wow.
2 months.
Can we get video of that? Is there?
There's that's out in the headquarters with it.
Okay.
So with that individual, the story is
That would be cool to
protected
show.
because it is. But
A patient.
but it is remarkable to hear that hey, there's a story out there, and you definitely want to share and give hope to other folks to know that hey, there's a possibility. And especially when there was nothing. The other places had basically said there's nothing else that we can do. So when you hear of a story of that, and then to see that the individual was able to walk, and that was 2 months, but then you go on to a year later where the individual is now walking by himself with a cane, it is truly remarkable.
That is amazing.
And now this didn't do it all by himself. The credit goes to the individual, his heart, his family, the support network of his other physicians and therapists, his OT, PT, all of those therapists that worked together to help him. It wasn't just, just the magic wand. It wasn't just the Merck coil that did it, but that was part of the catalyst to help get that connection, that neural network to go, okay, I can do this.
Yeah.
What do I need to do? And then, so just enhance that, enhance the ability of the body to heal and to understand that, okay, there is a potential. I can do this.
Well, even without Mert, I can give a personal story. You and I were talking about this off camera, but with my daughter, who was born with a cognitive disability called agenesis of the corpus callosum. And you being a big brain guy, you probably already knew what the corpus callosum was, right? So agenesis of the corpus callosum, that bundle of nerve fibers at the base of her brain, she was born without it. So she has these two hemispheres, right? There's my little brain, my two hemispheres. For those of you who can see it on camera, my brain. So Lizzie was born without her corpus callosum. Her neurologist said, gave us the worst case, who said she would never walk, she'd never talk, and she'd probably be bedridden. And at best case, he said, well, she might cognitively be, a 3 or 4 year old. Well, we didn't accept that diagnosis of never walking, never talking. We're like, we're going to help her and retrain her brain because that information superhighway is not there. Let's see if we can get the brain to compensate.
Right. And
it actually did.
Right.
But it took behavior modification. It took physical therapists.
Right.
It took speech therapists. And, she couldn't even nurse at one point in time as a child.
Right.
And, things like putting little different types of textures inside her mouth to get her used to the feeling of different types of shapes and sizes and textures of food.
Right.
Holding her over a treadmill and having a treadmill move and getting her body to understand that both of her feet would just flop on this treadmill. And then one day she takes a step.
Next step.
I was like a bumbling idiot.
Right.
It was beautiful.
Absolutely.
So when you take someone who has PTSD, traumatic brain injury, ADHD, any of these issues that are just debilitating, not only for the individual, but can be trauma for the family.
Absolutely.
You're finding a way to give them hope, which I think is beautiful. That here's another alternative to just popping a pill.
Right.
To mask the problem.
Right.
It sounds to me that Merck can actually provide a long-term opportunity. Can it heal them? Can they recover completely and not have to have any more magnetic therapy?
Right.
Is that possible?
So that's a good question. So as many of my patients, almost all of them, ask that, which is absolutely great. That's what we want to be transparent. And the response is that, yes, it can be. Sometimes the effects can be permanent and lifelong lasting, and that's it. Whether you wanted to call it a cure or just an improvement in their quality of life, that's what we're striving for. But I also advise individuals and patients that, hey, look, you can also mess this up too. So
how so?
So one of the big things is the sleep disruption. So my homework for all of our patients, and whether it's a child or a parent, is to make sure that you're correcting the circadian rhythm and sticking to a good circadian rhythm, that clock of the normal sleep and wake cycle. And with that,
is there a normal sleep and wake cycle for human beings?
There typically is. Yep.
What is that?
If we got away with all of our electronic devices and we just went out in the woods and Mother Nature and just lived it, you would start to normalize your clock probably within a week or two. Yeah. And that's because the natural sunlight rises.
These things here are putting off
absolutely
impulses, right?
Absolutely.
Energy waves.
Absolutely. And that's part of our education is when we're talking to folks. And you can see it on my website if you look on the patient intake form.
And Ian, make sure this goes up on the podcast and when it shows. So take me to where you want me to go right now.
So that if you go to the new patient,
okay,
all right, and then you'll see right underneath that what do you see?
Sleep and circadian rhythm.
There you go. So that's our pre-homework for the individuals is, hey, did you read that? Did you take a look? And are you following along with what we're giving you as homework? It's pretty good. It's pretty easy. I just tell you to close your eyes, and then when you wake up, get that sunlight. So we want you to get at least an hour of morning sunlight between the hours of 7 and 11. And the reason is that we're...
Please don't make my wife feel good about this because she's going to hit me after she watches this. I sleep with the TV on.
Yeah, wrong.
Okay, thanks.
Where's that? Where you got a button there? Oh.
Yeah, wrong. Yeah. That's
right. Mike Tyson would say it. This is why I bite people.
Yeah. Where's Mike Tyson at on here, guys?
Let it work. Just hit that other one. That one. Just let it sit for a second.
Nothing. Yeah, it's rhythms off. It's electrical impulses off.
Oh, yeah.
Oh, there we go. Yeah, really, Mike.
What can I say? Hydrogen bombs.
Yes. You're throwing hydrogen bombs at me. Kathleen's like, oh, got you. The doctor's orders. So how dark should it be?
So as far as the morning sunlight, let's start there. Of what we're trying to do is normalize that circadian rhythm of getting that sunlight.
So you're talking about coming out of sleep now.
Right, coming out of sleep and going outside. First thing in the morning, you wake up. Typically between 7 and 11, we want you to get that morning sunlight unfiltered. So don't walk outside with your sunglasses. You can't sit in front of a window because that's filtered light. We're looking at that 450 to 500 nanometer wavelength of light, okay? You step outside without sunglasses and the sun's out in the morning, it's just coming up, you're probably getting about 70,000 lumens worth of sunlight.
Ian, he's a light guy,
okay.
So in the movie industry. Can you recreate that, Ian, in a...
70,000 lumens worth of light?
I mean, there's lights that are bright, yeah.
Mm-hmm, sure.
Yeah.
Sure,
but real sunlight, the vitamin D from Mother Nature.
Mother Nature, that natural sunlight.
Okay.
And so we're trying to say, hey, at least get an hour of that sunlight. I know that's not necessarily realistic with winter and the working society we live in. So we do have the artificial lights. They're not great, but it's better than nothing.
Okay.
So I told my folks, one of these big companies that sells things that delivers to your house, you can get it for about $29, and it's a 10,000 lumen light. I tell them, buy one for your office, buy one for your house, put it in your kitchen or wherever, but in your morning, if you're getting your morning routine, right? The 3 S's, right? Put it in your bathroom. Get ready. Have that light. It doesn't need to be in your face, but off tangentially to the side. I obviously
those that don't know the 3 S's, I shower shave. I'll say it for you. There you go. You're talking to a Marine here,
right?
If I can't cuss 2 or 3 words, and
you got to get it in.
Yeah, right.
You got to get it in. But so the further distance away from the light itself, you lose some of that efficacy. So we tell you at least 2 to 3 feet. So if you're working at your desk, then okay, move it to your desk then in the morning. That's why I tell people have it at work.
Okay.
So leave it on, for at least an hour or 2 hours in the morning. And then what you're doing from a physiological standpoint is you're suppressing the melatonin that's being produced by the body. Now I know a lot of folks take melatonin because they need sleep. Well, your body already produces melatonin. So if you're helping the body's normal natural clock to normalize that, the SEN, the suprachiasmatic nucleus, sends that signal to the pineal gland in the brain to suppress the melatonin production. So that will last typically about 10 to 12 hours roughly or so. And so normally, naturally, all right, now 4, 5, 6, 7 o'clock at night, you start to yawn, you eat your dinner, you're getting a little sleepy. Well, what do we do as society? We jump on our tablets, watch TV, play video games, so all the things that can mess up your sleep. Yeah. So we tell folks, hey, look, I'm telling folks after 3 o'clock, try to wean yourself off of your mobile devices, your artificial light, and then as well as caffeine, tobacco products, nicotine, minimize that exposure to those in the afternoon. I've actually recently told a parent, hey, if your kid wants to play video games, have them play it during the morning or in the early afternoon. Minimize the evening time. It's not just the light. It's about also, you're talking about the Xbox. It's that excitation. You're playing games, you're engaged, and you get excited, right? So for kids, that's a huge stimulus. So we tell them, hey, if you're going to do that, let them do it early. I know you got schoolwork and stuff, but do that, take a break, 10 minutes, 15 minutes, but don't let it be, okay, now you can check out and go sit in hours in front of the TV.
8 hours
of right.
Gameplay.
Absolutely. Yeah. And it's the wrong thing to do. And that's why, so many of these kids are diagnosed with ADD, ADHD, problems with learning. Yeah. There's a disruption. A lot of them, you'll find out that they have a disruption in their sleep cycle. And that's not even going down the nutrition road of what are they eating. So,
wow. Isaiah, are you listening to this right now? So
Isaiah Gamer.
22 years old, 101st.
Oh, yeah.
I was just talking to him in the camera there. Yeah. That's the kid I was talking to this morning.
Yes,
hey,
yes,
listen to this.
Well, I have 3 adult children. My oldest is 27. I have a 24-year-old and a 21-year-old.
Dude, you don't even. And you told me earlier. I heard you're 50.
I'm 50. Yeah.
And I look 50. You look like you're still like 16, 17, man.
So genetics.
Yeah. The Asians, man. You like. You and black people, like black doesn't crack, and I don't know what the rhyme is for Asian people.
Asians don't raisin.
That's right. Asians don't raisin. There you go.
Or they do. It's really quick. So
Now we've offended every race today. What's
Yoda might be up there. So I may one day wake up and be looking in the mirror at Baby Yoda. I don't
That's
know.
Right.
So yeah,
Mandalorian is really cute on that show. Right?
It's the new thing. So right. So it could be trending here.
That's right.
But yeah, it's unique because with my kids, I had the same thing. I look back at the faults of my parenthood and raising kids, and I was there. Dad was the fun guy. Let's go play Xbox. Let's play PlayStation, whatever it is. We're going to play games and stuff. And actually my middle son here is a police officer here in Virginia Beach.
Nice.
So shout out to the Virginia Beach Police Department. But talking to him about, hey, what are you doing to help yourself? And you need good coping mechanisms, good coping skills to deal with all the stuff that you're seeing out on the streets, and certainly this political climate, all the things that are going on. How do you stay positive? And how do you help normalize your sleep cycle? He came off of nights or days, and now he's on midnights.
Wow.
And days that he's off. He just came off of a midnight shift, 12 hours, and he's having to go to court for 4 to 6 hours. And then what happens? He goes home. And he's supposed to sleep for about 4 hours, and then gets up and does it all over again.
Yeah.
So just helping him and understanding what he can do to help normalize that circadian rhythm. I said, did you use the light? Did you eat? Did you, So still a dad moment of, hey, do these
of course,
things. But, across the board, there's things that can be done. So back to the original thing of like, as far as the sticking point for these individuals, what can you do that can be a detriment, the disruption in the sleep cycle, alcohol consumption, and then medications. Those can be other things. I can't take away work stress, marital stress, but the alcohol consumption, that's another big component of educating people is that, alcohol, the carbohydrates, the thermogenic.
A toast once a week, okay?
Well, you're doing it early in the morning, so that's okay. So, so that's
5 o'clock somewhere.
The Germans had it right when at Oktoberfest, 9 o'clock the beer tents opened up, and then so if you're going to normalize it,
by 5 be done, right?
That's it. Cut it off. Well, that's as your your body is metabolizing the alcohol, the glucose, the sugar, the carbohydrates, and then it's an effect on its as metabolically it's processing urinary system. So all those different things.
Wow.
Your body typically cools off at night. So if you're now drinking alcohol alcohol, usually what happens, you get red you get
Right,
hot,
yeah.
and you can't stop that. Once it's in your system, you're talking at least a couple hours that it's now being metabolized. And if you pass out or you go to bed at 9, 10 o'clock, well, you're probably not going to fall asleep until midnight, 1 o'clock.
Wow.
Okay, get up at 5 and 6 o'clock or whatever and go to work.
So turning the TV off, all right, I'm convicted there. But at bedtime, how much light is too much light, or is there such thing? Is there a balance between how dark it should be in your room?
Yeah, I don't know of any specifics on what level of light intensity.
No
I think
studies
it's
really been done.
not that I know of, but I would say it's based on your personal preference. I know for myself that if the glowing light on my smoke detector is going off, or the illumination from my bathroom clock, the digital clock, or my bedside clock, or even my phone that's being charged, even if it's that little LED, that's enough that it can be sensitive for me. That if I roll over and I look up, it catches my eye. It's enough to cause me to like, okay, what's going on? So I've learned. Okay, I'm turning this off. I'm moving this.
Kathleen's going to love you.
Each individual is going to be different.
Towel over the clock.
Sure.
Towel over watch, phone.
Right.
She wants it
Right.
black.
Well, and that's a disruption in her sleep. So, obviously,
Oh, Kathleen.
a partner,
Talking.
right?
Yeah.
And your spouse, your significant other, and what's their adjustments? I'm sure you've got the one leg dangling out from the side of the bed on the sheets, right, and the other one. So I'm typically cold, and she's typically hot. So finding that balance of a good sleep environment is crucial.
Just kicks me out of the room. Go to the couch.
Doghouse.
That's right. The dogs love me.
Well, yeah, exactly. So, but it's
Confession today. It's good for the soul.
I know. Well, hey, we all live it. It's reality.
Or
right?
coming home from deployment, and all of a sudden you have a bedfellow again, and they're like,
right.
"Hey, can you go sleep in the other room?
Right.
You're snoring." Or
right.
Can this help with things like sleep apnea, or does it?
Not necessarily with sleep apnea. So with sleep apnea, you have obstructive sleep apnea, which is that anatomical
Double chin.
A little bit overweight,
right.
And so some of the body habitus can be part of it. Okay, it's not the only thing. What I've seen in some of our veterans was what we call central sleep apnea, and that's due to a disruption in the central nervous system. And a lot of our military folks that have sustained traumatic brain injuries may have a diagnosis of central sleep apnea, and that's where the neurological system itself is now not functioning in an efficient way. And having that deficiency, as you can understand, having that poor sleep habit, those poor sleep cycle throughout the night, you may just be going in and out of stage 1, 2, but never hitting the deeper stages of sleep, 4 and REM. Yeah. And that can have a negative impact on you in the long haul.
Which affects the cognitive ability of that person, which has all those other ancillary
Absolutely. On our website there, under the resources tab in sleep, that's the other part of my homework that I advise people to listen to. There's at least 3 of the base podcasts from Dr. Peter Attia and Dr. Walker.
Matthew Walker.
Matthew Walker, okay. Right. And those are great podcasts just to take a listen to, but they go into greater detail than we're going to about the poor sleep and its impact on the human body. All the way from the neuropsychiatric component to cardiovascular risks to the neuroendocrine component, so the effect on hormones as well. And it's eye-opening. I think once you start to listen to it, and you can get past some of the 100-pound brain stuff, it's truly remarkable. And even if you don't understand it, take a pause, do a little GTS. Right, Google that stuff.
Right. Okay, I like that.
And take a look. But I think once you start to find out, when you're looking at what's going on, a lot of the root of our problems have to do with poor sleep. And so, how do you normalize that? It's quite remarkable. So I definitely highly recommend anyone that's listening to take a look at that podcast. Those 3 podcasts.
So, how would a new patient get to? Obviously, and go to your site, NEUCOA.com, NEUCOA.com. Is there a place? What's on here where they?
There's a consultation.
Okay, so they could go to your site, request a consultation.
Right.
Can it be processed through their health insurance, or is it a pay only?
Right now, at this point in time, it's only just a cash paying. We
Okay.
are working. I have a medical insurance company that's helping me, a credentialing company that's helping me navigate the different insurance companies, as well as the Veterans Administration. We're not able to take TRICARE, which was a little bit heartbreaking for me because being a veteran.
Yeah.
But we are going to try to work with the Veterans Administration. I'm hoping that will open up the doors and allow that opportunity for us to treat certainly any of the retirees and the veterans in the area. So the other insurance carriers, so in particular, like my son with the Virginia Beach Police Department, their health insurance, just being able to know that, hey, okay, there's a treatment modality out here that's safe, it's effective, it's non-pharmaceutical. So that's a great hoping that we can get to that point to where we can accept the insurance. But it is billable or reimbursed to us just for depression. The other things are off-label, so typically the requirements, and those are made by the insurance carriers, are that, hey, you have to have had a diagnosis of depression, you tried 1 or 2 medications, it didn't work out, and now, okay, is this a reasonable treatment modality for you? Do you have any of the contraindications for the treatment? Meaning, what would prevent you from receiving this? So the things that we talked about. So we're hoping to get that.
So cash pay or patient responsibility until insurances come on board with this. What would a person expect to pay, and what type of treatment plan would? And I know it's hard to diagnose, and you probably can't diagnose over the air.
Right.
But just make a patient up for me and tell me what it would look like to treat that patient, what the cost would be, how long the treatment would be.
So what I've offered, especially with COVID, what I've told folks is that, hey, look, we want to do a 2-week assessment period or 10 days of treatment, okay? Then 10 treatments, and then around the 9th or 10th treatment, we'll repeat the EEG, take a look at the EEG. At that same point, when you do your initial EEG, we also have you do, there's 5 clinical questionnaires that we're assessing or evaluating for depression, anxiety, PTSD, and traumatic brain injury, so neuro quality of life type items. So PHQ-9, GAD-7, PCL-5, HUDAS, and NSI are the 5 scales that we have patients fill out. So we'll do that at baseline, EEG at baseline. Then around the 9th, 10th treatment, we'll have you answer those questionnaires again, and then we'll repeat the EEG. And once that's completed, about 3 to 5 days later, I'll have a follow-up with the patient specifically to go over their EEG results, to show what's changed in their EEG, and then I'll review their clinical scales as well to see what progress we've made with them. And what's remarkable is that, just take depression for an example, of the patients we've had, we've seen, this is our data, okay, to our company, we're seeing up to an 85% reduction in their depression symptoms just after 10 treatments.
Wow.
And that's not just depression. Now you move on down to anxiety, about a 67% reduction in anxiety symptoms. PTSD symptoms, same thing, about a 66% reduction. Quality of life, also around a 66-67% reduction on those 2 scales. It is amazing. And then when you look at it, it's just this one modality. There's no pill. It's non-invasive. You sit in a chair for 30 minutes to up to 36 minutes for the treatment. When you're done, you go home, you go back to work, you do whatever you want. Go surf, go for a run. But to have those effects across all of these different clinical scales is truly remarkable. And to know that, hey, we got you off your medications, you no longer have to. And I tell folks, look, we're not. This isn't curing you. It's allowing your ability to cope and manage with these things. Same thing if I were to give you a pill for depression or anxiety. It doesn't make those things go away.
Right.
It's just your ability to cope and analyze and handle that much better instead of everything being in your face and dealing with it now.
Yeah.
Now it's at the back of the room. It's 30 feet away. You can see what it is and target and say, okay, how am I going to handle this? How am I going to handle that? Whether it's work, whether it's family life, COVID, take your pick of things. So your ability to handle and manage that can be better.
Wow. Beautiful. So you're taking new patients.
Yes.
In terms of cost, what could a new patient expect over 10 treatments?
Yep. So each licensee is going to be different with their pricing point, so I can't give you specifics, but I will tell you that I do offer a military and veterans discount as well. Okay. So those individuals that want to come in, we do offer that discount. But I'll tell you that from just a corporate standpoint, the cost can be anywhere. If you're talking just initial, and that's the thing is I'm doing a 2-week. You can do it in 2-week blocks. Everyone's doing a little bit differently based on what their business model is.
Sure.
But for me, right now, we're talking about a 2-week block can range anywhere from $3,000 to $5,000, $6,000 for that 2 treatments. So when it boils down to it, you're talking maybe anywhere from $250 to $300 per treatment session. So it's really not. It sounds like a lot, but when you're talking about, okay, well, I can go take my pills, or how long are you looking at this from a long haul standpoint? Okay, am I going to be on these meds for the rest of my life?
What's your health worth?
Right. So, and if we can get the insurance, that's why it is a big driver for us to be able to help reduce those costs.
Do you help patients with? Obviously, you said military discounts and those warrior discounts that you're giving. That's awesome. Anything from a payment plan strategy, or is there any payment services that? Yeah,
I haven't worked with a finance company, but I'm pretty straightforward with the folks. Is that hey, I'm not holding you to a contract, so I'll just say, hey, look, if you're going to do this, then there's a $250 just assessment, the initial assessment in EEG, and then if you're going to start the treatment, then you just pay for half of that first 2-week block, and then the balance at the end of that 2-week block for the remaining balance, and then I'll deduct that initial assessment fee off of it. So building it in that 2-week block has allowed folks, especially during COVID, a lot of flexibility and opportunity. A large portion of the patients that I've had have actually been the autistic children and families that have been coming from out of state. So you would think that COVID was a hard time for a lot of folks, but it actually, since a lot of folks, I would say not everyone, but a lot of folks were working virtually, or now you're homeschooling your kids.
Bring the computer, bring the child.
Exactly. Yeah. Now it afforded them some opportunities. I've had several families that have come from out of state, as far as Alabama. Wow. To the northern east side of the United States, come up, and they've been able to come up and just do 2 weeks, and we're seeing remarkable changes in these children's lives. It's just so heartwarming.
So FDA approval is a big thing. Are there any regulatory guidelines for, like, the Commonwealth of Virginia? So when patients are looking and comparing you to the marketplace and what's available, what's kind of the gold standard for Merck and what you do?
Right. So the FDA has a set standard as far as what the treatment, as far as what you can make for claims, and I'm straightforward with individuals, let them know, hey, this is the expectation. We're not a cure. We're not, this is to help you as far as being able to, if it's get your quality of life back, your sleep. Mm-hmm. So there are regulations in place as far as the hardware, the software. There are some guidelines with it within the TMS treatment protocols, and so that we're following into those. So we follow what's under Wave Neuroscience and their guidelines as far as the safety protocols. So that's earlier when I was talking about the goal intensity, the motor threshold, the output intensity that we're treating each individual's. We actually have a bigger safety profile that's already built in. So the example is TMS that's out on market will treat to 120% of motor threshold, where we've scaled ours back considerably just as a safety profile for that. Can we treat to that higher end? Yes, that's been approved. But we feel that our goal is not to necessarily force the brain. We're gently training the brain to move to that optimal frequency.
Wow. So I'd love to keep going with this with you today, but you have commitments. I have commitments. I got a workshop I got to go do. I'd love to have you back on the show later. Maybe 6 months from now.
Sounds good.
I'd actually like to come and maybe put myself through this, or put my wife.
Absolutely.
Volunteer my wife. Maybe even let you talk with Lizzie.
Absolutely.
And maybe do an initial assessment and see where we fit on the spectrum of being able to help us.
Right.
If I can improve my brain.
Right.
And cognitive abilities.
Right.
As you can see, I'm a little slow sometimes. No, so yeah, I'm intrigued,
Absolutely.
and even talking to one of our mutual friends about some of this therapy that he's gone through himself, it really caught my attention to say, I want to talk to David Day and
Right.
figure out what you're doing. So
Thanks
thank you
for-
so much for coming
no.
and sharing with us.
Thanks for reaching out to me, and just let folks know that if they'd like to schedule the consultation, I also do briefs or tours of the clinic as well. A lot of my folks are pretty open, and I've got videos as well that I can show them during a presentation of what the treatment looks like and the expectations.
I would be remiss if I didn't ask you this. I always get to the end of the show and forget sometimes. Maybe with your therapy, I'll be able to recall better. I always like to ask executives, business owners, anyone I'm interviewing, what are you reading right now? What would you suggest that our listeners go out there and read and research, and whether it be for fun or for education, what's on your reading list?
The book that I just finished reading was called The Future is Faster Than You Think. So a lot of tech stuff, but having to do with the economy. And so I found that to be quite
The Future is
fascinating.
Faster Than You Think. Who wrote?
Yep,
Do you know who
yep.
wrote it?
No, I can't remember. Can't remember that.
We'll have the guys look it up.
Yeah, and I just started reading another book called Traction, which has to do with business as well, just the business enterprise. And I'm not a businessman. I'm a provider, a clinician that is now
who now
saying,
has been thrust into business.
Right. Has hey, figure it out.
Yeah.
So fortunately, I've had some good advisors to help me along the journey. So that I'm also reading a book on nutrition, How Not to Die. So
That sounds like a good one.
it's interesting, and it's about nutrition and more of a plant-based diet. So from that personal perspective, me being 50, I'm trying to figure out, what do I need to do to clean up my diet? Because that's the other component of our overall health is the gut biome as well. So I'm trying to.
I was listening to
navigate
a doc the other day on Rogan's podcast, and I can't remember the guy's name right now, but it was the carnivore diet.
Okay.
And he's pretty much all meat,
Okay.
and it is a little bit of kicking dirt in the face of the plant based. That's for a whole nother podcast.
Right,
Maybe we'll
right,
get back
right.
and compare notes one day and chat through that. But man, NEUCOA, you
Thanks.
guys are up and coming, doing some great therapy for our soldiers, sailors, Marines, and private citizens.
Absolutely.
So thank you for what you're doing, and God bless you. I hope it continues.
Thank you.
Great
Thank
success for you.
God bless you
And
guys
your
too.
patience.
And to all you guys out there, we appreciate everything that you're doing. So stay safe.
Yeah, roger that. Take care, guys. See you soon.